contribution made by IMGs in NHS, in health service, to prop it up as well as to run a healthy service. Why don't we celebrate it?
It's really important to state that the NHS was, by design, created or was built upon an IMG workforce.
Doctors passing PLAB in 2024, only 13% got a job within 6 months, which is comparing to 26% in 2022.
IMGs and ethnic minorities are disproportionately represented. So you've got so many IMGs filling these posts. Now, if those IMGs leave the UK, leave the NHS, actually, we would collapse.
Dear viewers, welcome to The Doctor's Voice. This program has been designed in order to highlight the issues related with health services. We all know healthcare workers work 24/7 to make sure that the nation's health is in a good condition, and they are there at a drop of a hat to look after you. In this program, we're going to highlight the hardships and the difficulties and the challenges they face in their career development, as well as in their day-to-day life and their working, in order to make sure they provide you with a good health. And we all understand that a healthy workforce can provide the best health service to the nation to stay healthy. We must look after them. And we are going to do a series of these programs in which we will address that, invite different delegates who are going to talk about it. It's a time to celebrate our contributions which we have made as ethnic minority health service workers to NHS over the years. And to start this program, I couldn't have had a better person than a person who actually has gone through the system, contributed towards it, and achieved the highest places which a person can do in this country. I'm lucky to have Professor Chaand Nagpaul. Thank you, Professor, for joining us. He has served for over 36 years as a GP in North London, and he was the first non-white chair of BMA, British Medical Association, which is a trade union of doctors in this country, over last 200 years. He has done a lot of work during his career as his chair, as well as before and afterwards, to support IMGs and ethnic healthcare workforce. I'd like to welcome you to this program. Thank you very much for giving us your time. And I'd like to start with you. Do you want to tell us about yourself first and the difficulties you faced? Although you were a local graduate, but still your color is like mine.
Sure.
So I'm sure you must have faced the same problems.
Sure.
Might be a bit different, but could you help us that first?
Well, first of all, Amir, thank you so much for inviting me on your program on such an important subject. So I wasn't born in this country. I came to this country at the age of seven in the late 1960s, when in fact racism was quite rife, and it was before the Race Equality Act was implemented. So I have memories of a very divided UK at the time. And with a large influx of Asians actually from East Africa. But I was schooled and educated in this country, in London. And I studied hard because I knew at the time that the only way I would succeed is to be able to achieve academically. In a way, it was almost assumed that I was living with unfair disadvantage. Now, I actually did very well at school. I went to university at St. Bart's Hospital, which was a very esteemed hospital and a medical school at the time. And in spite of actually doing really well in all of my CV was as good as it could be, I found myself, when I applied for GP training schemes, getting 9 rejections in a row.
God.
And that was in 1970. That was in 1985.
And I'm sure in those days, no one gave you the reason why you were not?
No, because there was no equal opportunity processes. Yeah. And it was literally a case of the sort of postgraduate tutor in the selection panel, just choosing who they would select for interview. And I was devastated. And it was only, later on when I went to my trainer and said, look, what's wrong? I mean, I've done everything as I should. I've got all the credentials, educated in this country, a CV that was as strong as it should be. And he said, you know what? He was honest enough. He was an English doctor. And he said, Chaand, it's your name and your colour. Because there was no equal opportunity at the time. So for my 10th interview, I actually took my CV to Charing Cross Hospital. I knocked on the door of the postgraduate dean, and I said, you are on the selection panel for the next round of GP training schemes. My name is Chaand Nagpaul. This is my CV. I really want to be a GP. Will you please give me a chance for interview? Now, that interaction obviously left a memory. I was called for interview. At the time, there were 180 applicants for 2 places. I studied for that interview like I studied for some final exams. And I knew more about general practice and healthcare policy on general practice than the interviewers. So in fact, I did get one of the 2 posts, and that was the beginning of my career in general practice. So I experienced firsthand. But actually, at that time, in fact, a couple of years later, there was a very important piece of research that was done by Sam Everington and Anis Ismail that actually showed that if you had 2 identical CVs, one with a foreign name and one with an English name, you were far less likely to get a job offer or be called for interview if your CV had a foreign name. So in a way, I was a living example of that fact. Now, I'm pleased to say that where we are today, we're not shortlisted on the basis of our name, but that was what I grew up with. The other thing I would say is that when I was a medical student, I owed my medical education to IMGs. Because you actually learnt when you were on call in the evenings, when you were actually in the doctor's mess, and you spent so much time with your senior doctor on call for the whole weekend. And what struck me was the doctors who were teaching me were registrars who were almost exclusively IMGs. And when I spoke to them, I sort of realized that these were doctors who were not getting consultant posts. And at the same time, the consultants, who were usually at home when we were on call, were largely white. So there was something that was clear in my mind, that these IMGs were not achieving the top posts in the NHS, and yet I knew how great and smart and hardworking they were. And so I was being taught by the best, but the best was not being recognized by the system. The other thing I found is that many of these IMGs, registrars, were describing how they were moving from one post to the other all over the country. So I'd be talking to an IMG who'd say, well, 6 months ago I was working in Blackpool. Next week I'm working in Margate. Then I'm going to Wales. Because they were actually going where the jobs were. They couldn't pick and choose where they wanted to work. And so the other thing that was imprinted in my mind was that we were in a society where a group of doctors who came from other countries literally were doing the jobs that others didn't want to do. And in spite of that, they had this incredible sense of service, loyalty, determination in being doctors in the NHS. And then when I qualified as a GP, and I came to my practice in North London, the other thing that was very striking to me is the number of Asian doctors who had served their communities for decades and often practicing in the worst premises, end of terrace housing. But gosh, they worked hard. They built up their list. They just were there for their communities. And the system didn't recognize them. And again, I felt this real sense of injustice, that here I was as a UK graduate, a GP coming in to my local area in North London, and I just was in awe of these doctors who had given so much of themselves. But also, one of the things I did at the time is I joined my local medical committee representing doctors, and one of the things I really tried to do was highlight that it was so disparate and unfair that you had a certain cadre of doctors working in these wonderful health centres, and a lot of these others who were largely from Asian background working in these poor premises because they weren't being given the same level of support and investment. So all these memories really made a very long-lasting impression on me. And so when I became chair of the BMA, the first thought I had was a sense of responsibility that I owed it to this incredible workforce of ethnic minorities and IMGs who had supported the NHS to actually, one, demonstrate and the recognition and the debt of gratitude that they do, that they're owed. And I wanted the BMA to really raise the profile, but also do something about the disadvantage that they were suffering and experiencing. So these are my real aims of mine.
Chaand, you mentioned quite a nice, important point there, the contribution made by IMGs in NHS, in health service, to prop it up as well as to run a healthy service. Why don't we celebrate it?
I totally agree, Amir. I mean, we're at a time now where we hear so much anti-migrant rhetoric, but when we look at the NHS, it's really important to state that the NHS was by design created or was built upon an IMG workforce. That's what the government did. It never intended or didn't create an NHS based upon a homegrown workforce. So we shouldn't be today talking about relying on IMGs because that's how the NHS was created. And from the 50s, 60s, 70s, 80s, 90s, successive governments have consciously promoted the NHS abroad to recruit doctors and enable doctors from other countries, largely the South Asian continent, to come to work here. And so the fact is that we wouldn't be sitting here today talking about the NHS had it not been for the contribution, dedication, loyalty, hard work of IMGs over those decades. And I was quite struck that going back to 1961, so we're talking about sort of, 60 years ago, in a Lord's debate, this is what was said by Lord Cohen of Birkenhead in 1961. And what he said was the health service would have collapsed if it had not been for the enormous influx from junior doctors from such countries as India and Pakistan. And Lord Taylor of Harlow said they are here to provide pairs of hands in the rottenest, worst hospitals in the country because there is nobody else to do it. And Amir, you were describing this yourself. So we need to, first of all, in my view, pay tribute, recognize and thank IMGs and that generation of IMGs that have allowed the NHS to actually survive to its current day. That's what we need to be doing. Celebrate their dedication and the work they've provided and the service they provided. So I think that's really important. And it's therefore not unreasonable that many have said that IMGs are the migrant architects of the NHS. So, we need to really spell this out. This is not, people coming here to take other people's jobs. These are people who've come here to provide service when this nation needed them to provide service.
And I think the present environment, it's very important to shout about it.
I totally
because
agree,
we should be telling people that the system would collapse if we were not there. I'm sure you must have seen the recent GMC report, which very credibly, if Charlie Macy, who is GMC chair, he said it clearly that it's a big worry that IMGs are going or not coming in. This will, NHS will collapse if that happens. How do you square this? That in this, I'm just looking at some statistics. If you look around in that same report, doctors passing PLAB in 2024, only 13% got the job within 6 months, which is comparing to 26% in 2022.
I think what this shows is that there's a lot of myths floating out there and inaccurate mantras going out there. So, for example, there is this myth that IMGs are the cause of UK graduates not getting jobs, because what you've just demonstrated is, in fact, IMGs are finding it very hard and in fact, are not being offered jobs, even if they had the right skills and credentials. So it's just not the case that IMGs are taking away. What we have in the UK is a problem of very poor workforce planning. The real problem we have in the UK is that we simply have too few doctors and, too few medical places for doctors, too few posts, and therefore that's why we have this bottleneck. And when you compare the UK to countries like Germany, France, they have 2 to 3 times the number of doctors that we have per thousand population. And we are about 46,000 doctors short compared to an OECD average. So because we have this ridiculously low number of doctors, and therefore you've got UK graduates competing for limited places, it's quite unfair, and it's just not correct and accurate to say that this is because of IMGs, because they're not the ones getting the jobs. So I think we do need to dispel that myth. The other thing to say is that the bottleneck is for these specialty training jobs.
Yeah.
However, there's tens of thousands of doctors working in non-training grades, in locally employed doctors, SAS doctors, staff and associate specialist doctors. So these are not training grades, of which IMGs and ethnic minorities are disproportionately represented. So you've got so many IMGs filling these posts. Now, if those IMGs leave the UK, leave the NHS, actually we would collapse. We wouldn't be able to provide a service. And we need to be very clear about that, because this mantra that IMGs is a problem is just not the case. The IMGs are actually propping up the NHS as we speak. And what's worrying is that we've seen, as you've just mentioned, a 26% rise in IMGs leaving the UK.
Yep.
And that's an increase on previous years.
Yes.
Now, if this carries on and we start seeing more and more IMGs leaving, and we don't see IMGs coming to this country, we've seen a drop of IMGs coming to the UK, we will end up with gaps in those non-career training grades, the SAS doctors, the locally employed doctors, and they are actually, also serving the NHS in a way that would not be, without them, we wouldn't be able to function. They're providing operations, they're providing clinics, they're, as we hear today, they are there working in the NHS on a day-to-day, hour-by-hour basis in a way that if they weren't there, we wouldn't have the NHS able to function. So we've got to be very careful with this sort of loose anti-migrant rhetoric, which can really, in the future, cause difficulties. There's another myth about the UK, which is, around IMGs coming here, staying, taking up these jobs. Actually, the majority of IMGs who work in the UK leave. And in fact, the UK has the lowest retention rate. Only about 35% of IMGs who come here continue to stay in the UK, compared to 82% in the USA. All these other developed nations have a far higher retention rate of IMGs compared to the UK.
Can I bring you on that, Tim? What's the reason for that? What do you think is the reason that those IMGs are not staying here, leaving, whereas when they're in USA, they stay there forever?
Yeah.
Because I remember when I was coming, the thing was, if you come to England, that means you get training and go back home. Whereas if you go to USA, you actually stay there and make your career in your lives.
Yes.
So what's the reason for this?
There are multiple factors. I mean,
Yep.
one is the visa requirements to stay in the UK have become progressively more difficult. Secondly, I think that many IMGs are experiencing, and we can come on to this later, huge disadvantage and poor experience. So many of them think, well, look, why should I put up with this?
Yeah. Let me take you on that. And the next, I think it's a very important thing, which you have just touched it as well, that IMGs are facing much bigger problems in NHS as compared to the local doctors, right? That we see, GMC referrals are much higher for IMGs than for others. What are we doing about it? How do we actually tackle it? And what's the way forward in that?
So we have an NHS that is based upon the founding principle of fairness, a fairness to treating patients, whoever they are.
Yep.
And yet, when it comes to the medical workforce, what we see is gross unfairness. And so when we look at ethnic minorities and IMGs at work, they're far more likely to suffer bullying and harassment. Repeated surveys, including a survey that I led when I was at the BMA. They are far less likely to progress in their careers, be offered jobs as you climb the ladder. And you said yourself, the proportion of IMGs that are offered top positions like consultant posts is small compared to the numbers that work in those lower middle grades. We also know that we have what's called differential attainment, where IMGs are far less likely to pass postgraduate exams compared to their white counterparts, which is one of the reasons they won't progress. But what I found just so strange about this is I know just how skilled, how bright IMGs are. You know, when I was a medical student, I did an elective in India, and I felt that I had far less knowledge than the equivalent students at medical school there. When I meet doctors from Pakistan and India, I know how bright they are. And you know, what we then have, when we look at this more detailed, there's plenty of evidence. The reason why doctors from other countries don't do as well in postgraduate exams is not because they're not capable, not because they're not bright, it's because the system around them does not support them. They don't get the right feedback, they don't get the right teaching, they don't feel included in the teaching and education, because we all know that you learn through a social construct with peer support. So they're isolated. And in fact, what I think has happened is that the UK has almost dumbed down the capability of our IMGs. Whereas in other countries, in some other nations, what they do is they try and get the best out of people because they know that the nation is stronger by getting the best. So I've seen lots of, look, I'm not a fan of the US health system, but I've seen lots of IMGs from South Asia who've gone to the USA and have progressed in a way that I don't believe they would have ever done in the UK, because you have a system there that really wants to recognize capability. We have a system here which actually does not give the brightest and capable people the opportunity if they come from another country. And so I think that's why we see differential attainment. And then the other, I did major work, a piece of work at the BMA called Racism in Medicine, a very large-scale survey that showed the daily experiences of ethnic minorities and IMGs was awful in the NHS. You know, more than half reported derogatory comments at work on a regular basis, compared to only about 7% of white doctors. And I could go on with all these, negative experiences. It affects the mental state of doctors. 60% of ethnic minority doctors say that their negative experiences at work affects their physical or mental health. And you know, when you are feeling bullied, harassed, if you're feeling stressed, if you feel you're being unfairly treated, affects your ability to perform. An organization called Civility Saves Lives shows that there's a 60% reduction in cognition amongst doctors when they're feeling stressed. And there's a 45 to 61% increase in medical error. So what you've also got is this unfair situation that IMGs are referred for disciplinary processes for between 2 to 3 times more than a UK graduate. And that's not because they're not good doctors, but they are actually working under this incredible stress. They're often scapegoated, and they're unfairly treated when it comes to regulatory referrals. So when you put all of that together, you can see that for many IMGs, they are leaving difficulties in terms of the system supporting you to be in this country, poor experience, poor career progression, unfairly treated. And I think that if we're not careful, we're going to see another wave of real rota gaps in the medical workforce. And we're now in a globalized environment where IMGs from other countries have a choice where they want to work. Yeah. And if they choose not to come to the UK because they perceive this as being a hostile country, a country that doesn't respect or value them, a country that doesn't enable them to achieve their best, they will choose to go to Canada, USA, Australia. And so, I just think we need to be careful not to, and there's no room for complacency, that what you see now on the one hand, it's medical unemployment and this inappropriate, misguided blame of IMGs could translate in the next 5 years to a situation where we don't have enough doctors filling those middle grades that actually our population needs in terms of a health service.
Yeah. Can I just bring you to another topic as well? Because I looked at some of the stats. There are about, I think, 49.9% of the hospital healthcare staff is ethnic, from ethnic background, minority backgrounds. Only 15% are in management, and only 11.3% get to a senior management role. Is that another reason why this hostility still exists?
I think those statistics highlight that, again, that we don't have a fair health system. We don't have equal opportunity. And I believe that by having this system which does not allow so many doctors who are from ethnic minorities to progress and reach the top of their potential and hold those highest positions in the health service, do you know what? The nation suffers.
Yeah.
It's our patients who suffer. It's doctors who are the brightest and capable who are not being able to provide their skills and contribution to our population. And that, I think that's something really important for the government to recognise, that if it really wants a health service that that releases its full potential, you need to enable every doctor, whatever their background, to become their best and allow them to become their best. So I think this just highlights that we still have a lot of work in terms of creating an equal health service that gives everyone equal opportunity to progress.
Yeah. With your involvement in all sorts of forums where these policies are made, you've seen this 10 years health service plan, how do the IMGs fit into that one? And what is the place for them going forward in it?
Sure. So the 10-year plan has made a very bold statement that it aims to have only 10% of the UK workforce being IMGs. Now, in fact, that statistic, I don't even know where that came from, because when you look at the proportion of IMGs in comparative nations, whilst the UK is admittedly one of the highest, a nation that has one of the highest proportion of IMGs in its medical workforce, it's not unique. Israel has higher, New Zealand and Ireland are very similar to us, and there's not a single nation in the developed world that has 10%. So I don't know where the government came up with this idea of 10%. It's unrealistic, it's unachievable, and actually it doesn't even make sense. We're living today in a globalized environment where people are choosing to work in different parts of the world. That's part of being part of a globalized economy. We've got UK graduates choosing to work in Australia, Canada. So, you can't control that. And I just think that the government needs to look again at this rather arbitrary and I believe illogical target of 10%. And that reason why that 10% is just not achievable is because also of who we are as the NHS. As I said, the NHS was never designed to just be to be built around a homegrown workforce. From its beginning, it was designed to have an IMG workforce. So we're not going to get to that 10%. So I do think the workforce plan has to be re-looked at. The maths needs to be done again. The workforce calculations need to be looked at. And what we need to do is really address the fundamental problem that we need 46,000 more doctors in the UK to reach OECD averages. Now, if we actually had a workforce plan that planned to increase medical workforce to the levels of other comparative Western nations, actually you would need more IMGs and every single UK graduate would have a job as well. So you would have no unemployment of UK graduates, but what we need is that capacity. And it's that lack of capacity that makes the UK stand out when people complain of these long waiting lists, going into hospital and waiting hours before a doctor can see you. It's because we don't have enough doctors. And that would be my message to the government. Have a workforce plan where we become literally the same as other countries, and you won't see this issue of unemployment.
That brings me to an interesting question, which probably is going to ask you personally now. You were the chair of BMA.
Yes.
BMA is the biggest trade union of all the doctors. So what role does that organization have in development of such policies?
A crucial role. Because remember, those ethnic minority doctors, the IMGs, who are members of the BMA, are actually contributing their hard-earned cash. And so the BMA, of course, has a duty as a trade union to support them. But you know, let's go back to the function of a trade union. Why do people pay a trade union fee? They pay for protection, for support, for advocacy when things go wrong. So we have ethnic minority doctors and IMGs who all the statistics show are at far higher risk of employment-related problems from their employer. You know, discrimination, unfair treatment, increased bullying and harassment, and so forth. So in fact, the BMA, and this is something I very much promoted when I was BMA chair, you know, has to provide that support as a sense of moral duty because that's what they're paying for. They're paying for their trade union to support them. So I do think that that is a core function of the BMA, to focus on the needs of IMGs and ethnic minority doctors, because they're the ones who are in the greatest need of trade union support, because they are the ones who are treated the most unfairly within the workforce. But also, the BMA is a professional body as well as a trade union. I founded, just during the pandemic, the first BMA forum for racial and ethnic equality. And that forum has given voice to large numbers of IMGs and ethnic minorities doctors in the BMA. And when I speak to them, when I hear from them, you know, the biggest thing that they're saying at the moment is the negative experiences they're having relating to anti-migrant rhetoric.
Yeah.
And I was just looking, in fact, on X, what was called Twitter, and I'm seeing fellow doctors writing things like, these IMGs who are coming to this country, who are taking away the jobs of UK graduates, these are the sort of mistruths that are being peddled. So when those doctors go to work and they are feeling vulnerable, they're feeling attacked, they're feeling that even patients and their own colleagues think that they shouldn't be here, that they're taking away other people's jobs. So they feel already pretty vulnerable, quite stressed, as if they're unwanted. And I feel for them. And in fact, this was the biggest issue that came up in the last BMA Forum for Racial and Ethnic Minority meeting that we had. And remember, many of these doctors who've come from other countries, you know, when they phone home and they phone their parents, their wife, they're going to just lie. They're going to say everything's fine. Yeah. So they're putting on this front and they're very alone. And I think we need to recognize that we're in a climate now where many are feeling frightened. We've seen racial attacks on some healthcare staff as they've walked into their car park. So we're also seeing not just racism in terms of verbal racism, but also fears of healthcare professionals from other countries feeling that they'll be assaulted and they don't feel safe. So I think it's really important for all of us as a community, and the BMA, of course, as a trade union, to make sure that any doctor working in this country is treated fairly and equally and feels safe and supported. This has to be a priority now for us, because doctors are not feeling safe, they're not feeling supported, and it is really stressing them and making them feel quite unwanted and vulnerable.
So does that mean that BMA has failed in its role to protect them?
Well, remember, the BMA can't control the way in which society functions, the discrimination that's prevalent, the anti-migrant rhetoric. But what it can do and must do is speak out and counter it. Yeah. And I think language is very important.
Yes. Very important.
Yeah. And so when the BMA speaks of issues around medical unemployment, where for specialty training, the language has to be very clear that this is not an issue about IMGs. This is an issue about the government not having enough training places. And that's the problem. And we've got to be very careful not to allow that anti-migrant rhetoric to mislead the public and other colleagues. So I do think the BMA has a role to be very clear about the root causes, but the BMA also has an important role to be there supporting IMGs in particular, who at the moment are feeling extremely stressed, vulnerable, and unsupported. So yes, that is the role of a trade union, and I very much hope that that is what the BMA will be doing, but that is the role of a trade union.
Great. Thank you very much. I'm sure this discussion can carry on for ages.
Yes.
Because there's so much to talk about. And this is not the first time you're coming here. You're going to be coming here again.
I look forward to it.
And we want to bring us some more issues which we
Yes.
want to discuss it. Is there a special message you want to give before I conclude this interview?
Yeah, I think that the message I would first want to convey is a big thank you on behalf of all my medical colleagues, on behalf of the population of the UK, to the work of IMGs and ethnic minority doctors. I really think it's important because, as we sit here today, the health service is functioning upon their contribution, upon them being at work. And we must, I think, recognize that and pay tribute to that. The second thing I'd want to say is that I think all of us, myself, yourself, Amir, Apne, BAPIO, the BMA, we all collectively, as organizations representing doctors, must collectively make sure that we dispel this anti-migrant rhetoric and the myths that are floating around at the moment, and make sure that we have a moral duty. And the message I want to say is that we will and we must collectively support you as ethnic minority doctors, support our IMGs, to actually feel that they are here and being treated fairly, but also being enabled to fulfill their fullest potential. And I think the message is that we're here for you. This program is part of that commitment. And it's not just our commitment, the two of us, but commitment amongst various organizations. So we're going to create a coalition of support because that's the right thing to do. It's what the NHS stands for, which is fairness.
Thank you. Chaand, thank you very much for your time. And it's not going to conclude on this one because I think there's a lot to talk about. And thank you. You have actually brought up the issues quite openly. And we're going to continue with these series in which we are not just going to talk about the issues, but also talk about the solutions. So I'm very grateful for your time. Thank you very much. I hope you all enjoyed it, and I'll see you next time.